Good morning, and welcome to Module 5 of the ASCRS 20 Happy Program, a masterclass in refractive cataract surgery. This is the fifth of 9 modules that compose this course, and on behalf of myself, my co-director, Dr. David Chang, and ASCRS, we hope that all of you and your families have remained safe and healthy during this very difficult time. We're sorry not to be with you in person, but we have the next best thing, and I think you'll really enjoy our program today. This program runs live every other Saturday through December, and it'll also be available online after the conclusion for several months following the course. So please spread the word to both ASCRS and non-ASCRS members. And please also be aware that this program is offered for free to residents and fellows. So I'm really excited about today's program. It'll have some really practical applications for you to take home to your own practices. Our main academic program today will be focused on practice management for the premium IOL practice. And I'm really excited to have two of the world's greatest experts on this topic joining us today to moderate. We have Dr. Vance Thompson and Dr. Kathy McCabe. So as an overview today, I'd like to mention that today's program will be divided into 4 sections. Each section will be composed of 2 to 3 talks, followed by an interactive live panel discussion. Then following our main program, which includes our interactive panel discussions, we'll have 3 breakout rooms. So you'll be able to choose which of the 3 topics you'd like to attend. Our first room will be optimizing customer service. The second topic is pearls for managing fees and staff in the premium practice. And the third room will be discussing integrating new technology and techniques into the premium practice. So we wouldn't be able to create programs like this without the generous support of our sponsors. And our corporate sponsors today include Alcon, Zeiss, Allergan, B&L, Johnson & Johnson, LensArt, Novartis, Ocular Therapeutics, RxSight, Star Surgical, Tracy Technologies, Centricity Vision, EyePoint, LensGen, Sun Ophthalmics, and Rendia. And in addition, we have received unrestricted educational grants from Alcon, Allergan, Centricity Vision, Johnson & Johnson, RxSight, and Ameris. Following the program at 1:15, we'll begin a non-CME corporate program sponsored today by RxSight. So you'll have to log in separately for that program. Today we have Vance Thompson, Steve Slade, and John Vukic who will be presenting in that program. So with that, I'd like to introduce my 2 moderators again, and I'll turn the program over to Kathy McCabe and Vance Thompson. Thank you so much to both of you for running the program today.
It's absolutely an honor to be here. And I think for those of you who have logged in, thank you for spending time with us. We're going to talk about something with premium practice, and that's going to help all of us take our practices to the next level. And I'm absolutely honored to be co-moderating with Dr. Kathy McCabe. Hi, Kathy.
Hey, Vance. Hi, Kendall. Hello, everybody out there. I'm super excited to do this program as well. I'm sure I'm going to learn a lot. It's always so stimulating to talk to our colleagues and really understand what we're doing right and what we might be able to do better. So excited for the program. And I want to introduce the first 2 talks today, which will be the premium refractive cataract practice, which Vance will lead us through. And then I will talk about practice principles and pearls for the premium IOL patient. And I wanted to just bring up a quick slide. As we were preparing for this, Vance asked me for a picture and I asked him for one as well. So you can see his adult photo on the right. And I was able to dig up actually a baby picture as well here. So if we click through, there he is. And so really, no nicer person in ophthalmology than Vance Thompson, and it's my great pleasure to introduce him to lead us through the first talk.
Thank you. Hello, Dr. Vance Thompson here to talk about a premium refractive cataract practice and keys to success. These are my financial disclosures, and just wanted to say I'm honored to be doing this with the ASCRS and co-moderating with Dr. Kathy McCabe. And as far as important keys, what I'm going to teach will help you grow traditional and refractive cataract practice, especially by understanding there's certain wants and certain needs in cataract surgery, and nothing has had more impact on my premium part of my cataract practice, and really understanding my patient experience cycle and looking at the experience with my team every step of the way. And having a caring, attentive team is so helpful to create a great experience. And we study the books on patient experience. I like to call it the science of nice, or the big E, the patient experience. And I think it's the key to thriving in modern day medicine and taking your practice to the level it can be. And so when someone's coming to our practice, I'm really thinking about patient education, and not necessarily what technology do I want them to understand so much, but rather what vision do you want? And do you want to do a lot with glasses or a lot without glasses? Do you want to restore just the clarity? Do you want to restore clarity and reading range? In a sense, I'm thinking, what kind of surgery would they want if they knew what I know? In this patient-centered approach, it's important to have them understand the lens used to do two things. It provided clarity and reading range. And now that we remove cataracts at an earlier stage because of reduced image quality, we're oftentimes reducing or removing their accommodative ability, especially younger patients that were taken to absolute presbyopia. And with that accommodative loss, they love to understand there's implants that will give them accommodative gain and work their way up the accommodation range again. So the second thing is understanding how to handle residual refractive error. Do they want to do a lot with glasses or a lot without? We know what to do with residual refractive error in traditional cataract surgery. We fit them with glasses. We need to have the same mindset with advanced. If a small refraction helps them see better, we do a corneal adjustable situation like PRK, LASIK, or AK. Or if it's a light adjustable implant, we adjust their optic. That refractive surgery mindset really helps. And doctors ask me, do I need a laser to perform premium implants? Well, if you haven't gotten a touchdown yet with their vision, you do need a plan. And so if they need an adjustment, you either do it or have a plan to refer. Setting pre-experience expectations is important. And I tell patients we're going for 20/20, but because of things like effective lens position and incisional healing, they don't always end up that way. And that's why there's various ways to take care of residual refractive error. And so if you're going to do an advanced implant, consider it multiple steps. We do the implant, we do the fine tune, if necessary, YAG laser capsulotomy, and all that's taken 3 or 4 months. And then we're giving it time. And I remember when Jack Holliday showed me this neural adaptation picture. If you just look at the blue dot in the center, each picture is equal. Now I show you the blurred left image, and I'm going to go back to the equal, and you're going to see by just staring at the blue dot that right image, even though they're equal, your brain was trying to equalize them out. And that's an example of neural adaptation. It's very real. It's why in a lot of FDA monitored studies for multifocal implants, patients are, pretty much happy at, a month post-op after you've hit 20/20, but they're really happy 6 months to a year. And it's because of neural adaptation. So telling them about that time is so important. Now we know the lens that's cloudy scatters light, and what we don't want to do is add it to a cornea that's scattering light. We got to assess the corneal optics. And if we look here, this patient, the cornea shows 0.7 high order aberrations. That's too high. And the topography looks a little funny. And I don't want to add a multifocal implant. Whereas with this, I can see the corneal high order aberrations are more like 0.1. I'm excited to add a multifocal implant to this clean corneal optical system. We got to have great diagnostics. And then as far as the business of what we do, we got to be clear about what's therapeutic and what insurance pays for and what's refractive, what they need to pay for. And we need to explain it well. And we need to send them away with forms that are really showing this in detail. Then we need to do great surgery. And to me, I love lining up Purkinje 1 and 4, and we're going to be talking in a future module how I do this, because really what I'm doing is centering the capsulotomy and the implant, so I get 360 degrees of overlap of the optic with the anterior capsule, like this. I don't want to have part of the capsule not overlapping in the optic and then get with capsular contraction, tilt, and decentration. That capsulotomy and performing quality centration of it and the optic is very important for a happy patient. And then as far as understanding what really moves your patient, they expect the technology, your talents, and your experience, but what moves them is how you treat them, your staff, calling them, thanking, it's basically how you made them feel. And keeping in touch, we call them at 1 and 3 months to make sure they're doing well. And if they're not, we bring them in and then finish. Sometimes 20/20 is not enough. If they have a small correction and it makes a difference, enhance it. Dry eye matters, treat it. Surface irregularities matter. If you're trying to figure out if they're real, do a gas perm over refraction. If it's crisp, it's their tear film or epithelium and you need to treat it. A happy and premium practice has a great experience. Patient education is comprehensive. Preoperative exam is complete. The refractive endpoint, you're nailing it. You're keeping in touch with these patients and you're reminding them this takes time. Our job is to finish. And if you do this, you're going to love having premium cataract surgery added to your practice. Thank you so much.
I'm Dr. Kathleen McCabe, and I'd like to share with you practice principles and pearls for premium IOL patients. These are my financial disclosures. Today's cataract patients are very savvy. They're on the internet, they're active, they're demanding, and they are a challenge as well as an opportunity for us to provide excellent care. And so sometimes you can see them a mile away. This patient may be an adventure waiting to happen, but you want to identify all of those issues prior to developing a surgical plan. So when a patient develops cataract symptoms, the first thing they do is try to gather more information. They're going to get online. About 75% of our patients have smartphones. They're using the internet, they're on social media, and they're consulting with Dr. Google. So you want to make sure that your presence on the internet is compelling, it's fresh, and it's something that patients can rely on as a way to get to know your practice and to feel comfortable coming to you for surgery. And all of our faculty have very compelling online presences, and you can see that here with Instagram and Facebook and web representations. Dr. Epitropoulos and many of us have a video on our website, and often that is referenced in our other social media that allow a patient to begin a relationship and start to feel comfortable with you as a surgeon and your practice. While waiting for their appointment, once they've gone on and they've called your practice or they've scheduled an online appointment with you, they're still gathering information. So they're viewing your practice website and any links that you provide. They're reading any information that you send in the mail, and they're watching online videos. And in fact, 82% of adults are on YouTube. And of our seniors, those that watch videos, about 3/4 of them are actually taking action based on the videos that they see. So you want to create a video presence as well and provide links for that on your social media and on your website as well. So here's another example of ways that you can connect and educate your patient. Sometimes it's just providing a link to something that's non-branded like My Cataract, or providing videos that describe the disease process. When they come in, they're going to get their evaluation and diagnosis. And in your office, they may also be watching videos or reading literature or speaking with your staff. And it's really important to continue to educate the patient of these opportunities and to also have a consistent and concise message. The exam with the doctor is the best place, though, and that's where you need to educate the patient on what's going on, what a cataract is, again, using clear, concise messaging that's consistent with the message and language that they've heard throughout your practice and on their journey so far. Visual tools are helpful. They should have information to take home. And most importantly, the surgeon should make a very clear recommendation as far as the choices go. And also a reasoning why certain technologies may not be a good option for the patient, so that if they call in with questions later, your staff has the same consistent message about what is available to the patient and why. Pre-op lifestyle questionnaires are helpful. They let you know what the patient has as priorities. Written questionnaires are great, but there are other technologies as well as Vivior, which is a way of sampling what the patient does during the day to see what percentage of the time they're either participating in distance, intermediate, or near activities, and that can help make a recommendation for technology choices to provide to the patient to reach their needs. So again, videos, imaging tools, anything you can do to sort of educate the patient and have that consistent message and let them know what their options are helpful. And I find that there are a number of these many of those include some of our preoperative testing technologies that we can then present that information to the patient about their own eye so they understand their own eye health better. We might do that with a hybrid visit, with a telehealth visit, so that that's actually involving more family members, and that can help with patient understanding. But you want to identify any problems preoperatively and illustrate those well to the patient so they understand what's going on, and that helps to develop buy-in for any management that must be done prior to measurements or even prior to their surgery. And if you can show the patient that they have dry eye and what that means to the ocular surface, or that they have other problems that need to be addressed, that will help not only identify the problem as something the patient has preoperatively, but help them to understand why there might be a delay or other procedures necessary before surgery. You also want to identify problems like early glaucoma or macular issues like VMT or a small subfoveal PED, so that you are recommending the appropriate technology and that the patient knows why certain technology may not be appropriate. But again, a picture is worth 1,000 words, and helping to show the patient exactly what to expect with different technology choices is helpful in really gaining their understanding and helping them to understand the importance of really a lifelong decision that they're going to need to make. So you want to show them any potential side effects that are appropriate for the technology being recommended. And don't be afraid to discuss price. This is actually a little informative video that we have on our website. It goes over pricing and options, as well as letting the patient know that there are financing options available as well. So patients aren't surprised by the fact that they're going to have some options. They're going to need to make a decision, and there is a financial obligation associated with that. After diagnosis, while they're awaiting their surgery, they're again consulting with their family and friends, they're searching the internet, and coming to a final decision as far as surgery goes. And you want to, again, make sure that patients have access to good information, and sometimes you can actually feed that to them with certain technologies like Ocular Innovations, which will send reminders and text messages with links that allow patients to gain more information in a stepwise fashion. After surgery, you want to refer back to your same preoperative discussions using the same tools and language. Partner with a patient to achieve your mutual goal of excellent vision and satisfaction, and identify and treat any complications or other problems as they develop in the postoperative period. So in conclusion, there are multiple points of contact with the patient. You want to identify educational opportunities, and this will lead to more informed patients. Better informed patients have more realistic expectations. When you're able to meet and exceed those expectations, it creates happy patients, and happy patients create happy surgeons. So thank you very much for your attention. I want to thank our presenters, which were myself and my co-moderator, Vance, and we're going to move on to a panel discussion at this point. On our panel, we have Vance Thompson, Alice Epitropoulos, Carrie Solomon, and I think that John Doan will be joining us in just a few moments. So, you know, all of you I know have really successful premium IOL practices. And I love the way that you put that, Vance, that it's important to get buy-in with your staff, and it's important for them to be educated and committed to the science of nice, as you put it, which I just love that. That's what makes you Pooh Bear, right? So what are some of the tools that you use in your practices? And I'm going to start maybe with Alice actually for this, which help to keep your staff aligned and giving the same message to your patients. So how do you do that?
Well, you know, I think that, you know, sending information out to the patients early is very important. This way, you know, patients know their options before they actually come in, and they know the language and the terminology. You know, and I like to kind of, you know, make sure that we're giving a balanced discussion on the surgical options. So I don't like to be pushy. I just like to educate them as to what's available out there. And I have my staff do the same thing.
And, you know, Carrie, same thing, like who's the first, how do you get the first educational materials to patients who are coming in? Do they get an opportunity to kind of think about those options for your premium practice prior to entering, or what's the first interaction for them?
Yeah, great question. So You know, I do believe similarly to Alice. I think the sooner we get them the information, the better. I'm a big believer in teamwork and in keeping it simple. We don't want to overcomplicate things. We don't discuss in advance specific technologies, be it laser or multifocal or extended depth of focus. It's more or less patients have choices about being less dependent on their glasses, and they can see in the distance, or they have options to see distance and near. We send all that information out in advance of their appointment. It's on our website and social media, and we direct them to that as well. And I ask them to bring a family member with them, even in this COVID environment. They stay outside until they come in for the exact consult, the final consult with me, and then they do come in the lane with us. And I think that helps to not only help with understanding, but also takes things like price off the table a little bit, because people are less willing to spend money on themselves, but with family members, I think it makes the money discussion a little bit easier. But we do send information out in advance. I think it does help.
And I know that Vance, you talked a little bit about neuroadaptation. I loved your example. It worked for me. I had to be really surprised with how quickly, that makes a difference. And I think it's a great illustration. Do you use that for your patients? Do you show them something like that to explain that?
No, I don't use it, but I do explain to them, what we saw in the FDA monitored trials and patient satisfaction being good at a month and great at 6 months. And I like them to understand it's their brain getting used to their new optical system. But I also remind them that's not really starting the best way it can until they're at 20/20 uncorrected in each eye. They're going to have a hard time neural adapting if there's 20/30 with residual astigmatism. And so I explain to them that step one is to get them to 20 happy, which is usually 20/20 uncorrected. But step two is your brain getting used to your new optical system. And if you're someone who's not going to be patient, it's probably better to just do a traditional implant. Let's get your new glasses at 4 weeks and be done with this. But the patients that really understand and you set those pre-experienced expectations, it really helps. But you also have to remind them because they can forget.
As we all do, right? Patience is the hardest thing for anything, at least. Well, we're all cataract surgeons who like quick surgery, so probably not the most patient bunch. John, I know you're going to walk us through kind of that enhancement period and how you approach that. And I'm excited to see your talk. Do you have any pearls on like when you decide to address those things with a patient? How often do you hold their hand, and how long, I guess I should ask, before deciding that it's time to take action?
I think it really boils down to obviously patient happiness. The one thing I don't want to do is I don't want them to linger and be unhappy. So whatever I need to bridge that gap. So if it ends up being a contact lens, glasses, whatever, I simply don't want a patient stewing. And that really starts, I tell them with any intraocular lens, so let's say a premium lens, especially presbyopia correcting, I'm not going to do anything for 28 days. I'm going to let them stabilize, but I'm pretty much doing something at day 28. So if I know that they need let's say a laser vision correction, that's when that's going to be done. Now, if they're completely off target, if it's a toric, and I know at week 1 that they are not aligned, I'm going to do a rotation early on. So I think that's important from that standpoint to not let them linger and be unhappy. I hope that helps that concept.
Great. Yeah. And so what I was wondering too, I know that, getting to the point where you have excellent, happy patients is all of our goals. And we do a lot of work intraoperatively, preoperatively, and postoperatively. And Alice, you've been really a very educational colleague of ours talking about the importance of optimizing the ocular surface. And I know you've developed really a dry eye practice around that. How has that helped your premium IOL practice?
That's a great question. I think that if we can educate the patients about the importance of really optimizing the health of the tear film, explaining that really helps to allow us to select an accurate power for the implant, regardless of what implant we're going to be choosing. It helps with the healing process. It helps to maximize their visual outcomes. And they're more willing to, be compliant with their treatment and, understand if we need to delay their surgery. for that reason.
That's great. And Carrie, I know that you do some of the same things as well. Do you ever have any conflict or competition with any of the OD practices that are referring to you in trying to address dry eye, or do you refer those out mainly to their referring doctor for that?
Well, typically, and with the referring doc, and more of the ODs are getting much more proactive at managing dry eye, which is great. The other thing, which I'm sure we'll talk about, is the technologies are getting so much better. We used to just have multifocals and we just had one ad. We have multiple ads. We have extended depth of focus. We have new extended range lenses. We have light adjustable lenses. So these days we have lots of options. So I keep it simple, but then match the technology that I think is going to meet their needs. So it's a pretty straightforward process.
Well, I want to thank everybody on the panel. Lots of great ideas to reaching 20 happy with our patients. And we all know that that leads to 20 happy surgeons as well.
My name is Dr. Alice Epitropoulos. It's a pleasure to talk to you about educating our cataract patients in today's premium world. We as refractive cataract surgeons are facing a new set of demands as patients continue to have higher expectations for a greater range of quality vision. Educating and counseling prospective patients on the risks, benefits, and setting realistic expectations is necessary for medical, legal, moral, and ethical reasons. Patients who have a poor understanding of cataract surgery tend to be associated with higher dissatisfaction rates, more anxiety, and less compliance with perioperative instructions, all of which can increase the risk for adverse outcomes. These are my financial disclosures, and I have no conflicts related to this presentation. Patient education should be a multifaceted effort. All levels of care should work together as a team. The surgeon, staff, and counselor all working together towards a common goal by providing the best quality of care, exceeding patients' expectations, and delivering premium results. To make the education and counseling process as efficient as possible, you can use videos, a variety of printed materials, and most importantly, physician extenders or our staff. This can begin prior to the initial consultation by mailing educational brochures with a personalized letter to patients who are scheduled for cataract consultation. The letter can include instructions for patients to visit the practice website where they can read about premium lenses and watch informative videos. Alternatively, we use a cloud-based software called MD Backline to reach out electronically to patients scheduled for cataract evaluation to collect information such as their medical history, visual complaints, lifestyle, and visual needs. Patients also receive educational materials prior to their initial visit, which allows them to come in more prepared and more knowledgeable about the procedure and the available technologies, including premium lens options. We spend as much time as needed in a no-pressure environment until patients understand the preoperative, intraoperative, and postoperative steps of the procedure and thus can make an informed decision. Patients are encouraged to take their time in making this decision, as this is a once-in-a-lifetime opportunity for them. Patients can get overwhelmed with all the information that we provide to them during their consultation. So having a family member or a friend available to listen in on the conversation is helpful. I've always believed that 2 sets of ears are better than 1. We also make sure that our patients leave the office with written documentation, including the various premium lens options that they qualify for. And no matter how surgeons choose to educate and counsel patients, the goal should never be to pressure patients to go with the more expensive technology, but to educate them to what their options are and then let them decide. Not everyone is a candidate for these premium lenses. Pre-existing conditions, including maculopathy, irregular astigmatism, anterior membrane dystrophy, or severe dry eye disease may influence the choice of implant that we use. But even for those who are not candidates, we should still explain to patients that this technology is available but that they're not a candidate. This way, if their neighbor, for example, who has to wear glasses, receives a multifocal lens, they don't get upset that this option wasn't provided. Educating patients that have a pre-existing condition such as dry eye disease on the importance of managing the condition prior to surgery is critical. You can show patients a photo on how dry eye disease can distort their vision and reduce the accuracy of the implant power that we select. And then the difference that treatment can make. If we can explain that ocular surface disease is one of the leading reasons why patients are unhappy with their surgery afterwards, then patients are more likely to understand why their surgeon may be recommending delaying surgery, and also helps to motivate them to be more compliant with treatment preoperatively. I like to inform patients about the various implant options that they qualify for and then let them choose based on their desires and lifestyle. After the consultation, the surgical coordinator should meet with them and further educate the patient to facilitate the decision-making process. This is a great visual that can be used to educate patients on how astigmatism can affect their quality of vision and the value of correcting astigmatism with a premium toric implant. This is another great visual explaining the difference between a presbyopic correcting implant and a standard monofocal lens. It's also important to counsel patients on the potential downside of these technologies, explaining that there's no perfect lens. The surgical counselor should review these options, the value of upgrades, discussing out-of-pocket costs, including premium lenses, insurance deductibles, copays, and discussing affordable payment plans that may be available. It's important to keep lines of communication open to address any additional questions. I'd like to thank Rendia and MD Backline for providing some slides for this presentation. Again, I have no financial interest in these companies. In summary, careful selection of candidates through preoperative education and counseling, along with high surgical skill, all greatly increase chances of success and surgical outcomes. A team approach to decision-making works well with the counselor, surgeon, and patients all working together to identify the implant that's going to work best for that individual based on their lifestyle and vision goals. Thank you so much for your attention.
Today I want to talk about preoperative planning and preparation for premium cataract surgery. I do want to represent my conflicts of interest. Today's process for planning for many of us does require lots of printing, reams and reams of paper, from the health record, electronic or otherwise, from all the diagnostic devices, and then we manually assimilate that information to develop a surgical plan. It's labor intensive, it's inefficient, it's prone to mistakes, but fortunately most of the time it's quite successful. As part of this process, I believe it's essential that we include devices such as corneal topography and OCT analysis of the retina in order to screen and identify the best candidates, as well as avoiding those candidates that would not be great selections for premium IOLs, such as the corneal topography on the right or the OCT analysis on the bottom. Once we've identified the right plan and the right candidate, then we have to make sure we hit the target refraction for the visual goal the patient's looking to achieve. So the first thing that has to happen is the spherical equivalent, and we do that with biometry. It's important to make sure that we do what Warren Hill calls the pre-flight checklist, making sure the axial lengths are similar between the eyes, the average Ks are similar between the eyes, etc. Because at the end of the day, if it's a bad test, garbage in, garbage out, we're going to get a bad result. So it's important to do this. Fortunately, most of the modern biometers today have checks and balances built into them, but it requires attention to detail and make sure that we recognize when the device is telling us that we need to repeat the measurement. Nonetheless, this is how we get spherical equivalent for our target refraction. And then we have to address astigmatism, which has its own separate set of challenges. We have to deal with magnitude, we have to deal with axis, and we have to deal with posterior corneal astigmatism, or total corneal astigmatism power. How do we arrive at the right solution for each and every patient? And what do we do with varying measurements between devices? Because these days, Most of us use multiple devices. I prefer to use at least 3 devices. I learned this from Graham Barrett. But they all measure slightly different areas of the cornea, and they all give you slightly different results, as they should. Which one do you use? How do you know what to go with? Here's an example of a minute keratometry that shows 1 diopter at 90 degrees. In the same patient, the biometry shows 1.15 diopters at 108 degrees, almost 20 degrees difference in terms of the axis. And the corneal topography in the same patient shows 1.5 diopters of astigmatism at 85 degrees, almost a 25 diopter difference in the orientation of the astigmatism, and about a half diopter difference, a 30% difference in the magnitude. Which number do you use? We'll talk about that. Then what most of us do is we take all this information that we printed out, and we as the physicians or our staff help compile the information and develop the surgical plan. Again, it's labor intensive, but we have to be thorough, we have to pay attention to detail, make sure we have good data, and then develop the surgical plan. This day and age, there has to be a way to take advantage of the digital data and the digital environment that we live in to streamline this, to reduce errors and improve efficiencies, and reassure us and better assure that we're going to come up with the right plan for the right patient. And that's starting to happen. This is a digital software system by Zeiss called Veracity Surgical, where it takes the EMR data, takes the patient's input, all the information from diagnostic testing, and it does this with no manual entry because it's automatically hooked up to these different devices. It assimilates this information, it automatically scrubs it and looks for errors, and then it presents a surgical plan based on surgeon's own preferences and based on the patient's input for what's going to solve the problem. It's simple math. So here's a patient who says they've never had refractive surgery, they would like to be less dependent on glasses for distance and near, and they've never done monovision. My personal preference in this case would be Alcon's new Vivity lens, so the software is going to default to that. And it's just solving a math problem. In order to achieve this for this patient, it needs a toric lens to get a planar result in both eyes, as you see. And it's already selected the lens that I have already identified as my preference. Each surgeon selects their own. Also, automatically, it pulls up all of the modern formulas, and you can see nice consistency between each of the eyes with the formulas, and that's also very reassuring. Also, it looks at both astigmatism formulas, the Abalafi-Koch and the Barrett. And once again, those are the formulas that take into account posterior corneal astigmatism. Now here's varying devices, a Pentacam, a Lenstar, and an IOL Master. Notice the magnitude of astigmatism and the orientation of the axis of the astigmatism is different between the devices. How do you know which to use? I prefer to use the Barrett Integrated K, which Graham Barrett developed. And this takes into account small differences between devices. I've had very good results with it. It does require manual entry. You don't need a digital system to use the Integrated K, but if you're using a digital system such as Veracity, it does it all automatically. Now this is kind of a fun feature. Because I've got 2 different biometers here, I can toggle back and forth and just reassure that that diopter difference between the eyes is real and consistent between both devices. It's not necessary because the software is built in to scrub the data and present that to the surgeon if inconsistencies are present. Now this also does the operative note. So we're going to go ahead and identify that we're going to use femtosecond procedure. Now we're going to address the alerts. This is brought forward. No one entered this from the EMR and from the diagnostic devices. We simply address those as whatever needs to be addressed. And then we can go ahead and approve the plan. Once the plan's approved, I can show you what it would look like in the operating room. So the plan's approved. It's automatically available in the cloud. So in the operating room, when you walk into the room, for Jimmy Barnes, this sample patient, this is what would show up on the screen in the operating room. It identifies the make, model of the lens, the orientation of astigmatism, and anything that's been specially noted. Here's the op note ready to go. And since we specified this was a femtosecond procedure, you'll notice that the femtosecond procedure narration or narrative is already incorporated. If I do something different in surgery, such as insert a capsular tension ring, you can see that's automatically put into the op note. It's red to highlight it for now, but when we do print it by hitting the blue button in the lower right corner, everything is black and looks uniform in the printed or digital operative note. So the Veracity surgical system takes all of the preoperative data, but without any manual entry. It's automatically assimilating that based off of surgeon preferences and patient desires to come up with a surgical plan. And once that happens, that information is then sent into surgery via the cloud, and you can pull it up on any computer, and it's also hooked up through Zeiss Callisto's image-guided system. And then post-operatively, because it interacts with EMR systems, it can pull K readings, it can pull refractions, etc. So you can do data analytics. It takes all of the demographic information, and it can also do optimizations automatically with no manual entry. It integrates with any EMR system, and you can actually use it without EMR systems at all, but it does require manual entry, and it does work with multiple devices. Other systems out there, the Alcon Cataract Suite, using the new Argus biometer from Alcon, has a planner in it that's fairly sophisticated. It does require some manual entry at the moment because it does not currently integrate with electronic medical records, although Alcon is in the planning stages of developing that as well. Once the plan is developed, it is sent wirelessly and electronically to the Aura system in the operating room, intraoperative aberrometry. The Aura system is then used real-time in surgery in the aphakic or pseudophakic state to fine-tune the power of the lens, the spherical equivalent, as well as the magnitude of astigmatism and the orientation for those that use the Aura device. And once the surgery is completed, on the post-op end, the surgeons or their staff can enter the post-operative data back into Aura using the analyzer, and this will provide data analytics and optimize surgeon factors as well. It does require manual entry at the moment, but again, this system is in development with Alcon to only continue to improve it along the way. So in summary, preoperative planning and preparation for premium cataract surgery is absolutely essential. It's important to pay attention to details, and as our surgeries become more complex, as our options for patients are more detailed, and as patients' expectations only continue to go up and up, it's important that we pay attention to absolutely every piece of information and try to assimilate all of the information to get the right plan for the right patient and hit the target refraction. Manual entry and manual looking at the data and evaluating this is very successful. Digital software products are coming along. At the end of the day, our goal is to have happy, satisfied patients, and if we do this in the modern era with premium cataract surgery, we're not only going to have happy, satisfied patients, but we're going to be improving the quality of our patients' lives. Thank you very much.
Hey, great talk, Alice and Carrie, and we're going to have a nice panel discussion on what you guys presented with Robert Maloney and Michael Dubkowski, in addition to you two. And Robert, I think I'd like to start with you. I think you were one of the very first practices that I got to really see a great patient experience. And, you know, when Alice talks about all the information that it takes and the education process, I think it's one of the most intimidating aspects of adding premium cataract surgery to a lot of practices is, you know, just making sure the patients are fully educated on options and pre-experienced expectations, and that they go into it with the best chance of patient satisfaction. I personally find, you know, years ago, before I saw folks like you using their staff fully, that would get fatiguing trying to do all that myself. And how Alice talked about physician extenders was so beautiful. How educated is that patient in a cataract consult when it finally gets to you?
Such a great question, Vance, because certainly what exhausts me in clinic more than anything else is patient education. I mean, it doesn't seem like a good use of my time. It tires me out. It seems to go on forever. We've worked very hard in the last few years to get our optometrists to do the patient education for us. And that doesn't free me of the responsibility, but it really reduces the burden on my partner, Dr. Shammy, and I. And so Alice is, I think, right on target when she says physician extenders are critical here. Previously, we had our techs doing it, and they really just they didn't have the medical judgment to be able to do it effectively. The other thing I think is very important is to not give patients many choices, hopefully as few as possible. And the reason is choice paralyzes people. It's hard to make choices. So I'm always very careful to ask a lot of questions, try and understand their needs, and then just make a single recommendation. We obviously present their options, we make a recommendation. This lens is what I would recommend for you. Then at least the decision is just yes or no, and not this lens or that lens. So that'd be the two pieces of advice I offer to our colleagues.
One of the things that you just said that I think is so huge for someone just getting into premium is make a recommendation. And, you know, lots of times I'll say to patients, if you don't mind wearing glasses, there's no reason to invest in all this advanced technology. You know, traditional implants work great, but if you value doing a lot without glasses, and so what I'm doing is I'm trying to tease out of them what they value and make a recommendation based on what they value, not necessarily telling them what to do. And Alice, you know, how much time do you spend with your team on making sure that they're aligned with, you know, your ways so that there's consistency throughout the process? Because I loved how you presented it so clearly. How much team prep?
Well, we try to have quarterly meetings with our team just to kind of try to make sure that we're all on the same page. Sometimes we'll have new technicians, and I'll take some time to really educate the new technicians as to how, you know, we, you know, like to educate our patients about the different technologies. But I think it really, you know, kind of making sure that you communicate with your team on a regular basis really goes a long way.
I feel the same way. Carrie, how about you? How much time you spend educating your team on this stuff?
It's a constant work in progress, and I have a great team, but you know, the truth is it's such a great investment. My team does a great job. So by the time the patients come to me, they pretty much know what they want to, what their choices are, and they pretty much know what they want. So it's a much more streamlined process for me.
I also think it makes workplace joy better for your team. I sometimes feel like I work for millennials because their reasons to do what they do and wanting purpose and all those things. When you spend time with them and empower them to help you with this process, it's amazing what it does for your employee culture. And, you know, Michael, really looking forward to your lecture in a bit, but one of the things that I, you know, wonder with someone with your knowledge and expertise, we have print media, you know, we have digital in video, and we have various ways of learning. How much do you recommend, you know, kind of mixing it up? Or is there, do you think video should really be an integral part of it all and not just print? Any opinion on that?
Oh yeah, I mean, my opinion on video is very high. I think that something everybody needs to have in their program. And I liked what you had to say about the culture piece. And I also wanted to say I liked what Alice had to say about you know, patient education and MD backline. I think that's a very smart thing. One thing I might throw in there for a physician extender would be not just think about the patient experience, but what happens pre-patient. When someone's kind of researching who their cataract surgeon is going to be, they become interested. That's another great point for patient education. But back to your question about video, I absolutely think that telling your story is vital. And you know, telling your story about how you want to give the best vision is critical.
Thank you. And this panel has been just wonderful. We're going to be, you know, seeing more of this stuff as we talk in some of the other talks, but I think we need to move on to the next session now. And it's going to be on compliance and patient shared billing with Kevin Corcoran, and out-of-pocket payment and financing with Pat Barkey, and handling fees for enhancement decisions with John Doan, and then a great panel. Thanks, team.
Hello, my name is Kevin Corcoran. I'm president of Corcoran Consulting Group. I appreciate this opportunity to join the distinguished faculty of the ASCRS's 20 Happy in 2020 Comprehensive Master Class in Refractive Cataract Surgery. This is my financial disclosure, which is relevant because our firm provides consulting for ophthalmologists and optometrists on reimbursement and compliance. The information in this program is not an official source, except where specific citations are given. There are two important Medicare regulations relevant to presbyopia correcting and astigmatism correcting IOLs and related services. The first, published in May 2005, is CMS's ruling 0501 that designates presbyopia correction at the time of cataract surgery as a non-covered service and the beneficiary's financial responsibility. On a cautionary note, Medicare warns that the physician and the facility may not require the beneficiary to request a presbyopia correcting IOL as a condition of performing a cataract extraction. In January 2007, a second regulation was published pertaining to astigmatism correction at the time of cataract surgery. The language of both policies is remarkably similar, as you can see from this excerpt. While payment for non-covered services is the beneficiary's responsibility, Medicare law contains a provision that waives that liability if the beneficiary is not likely to know and did not have a reason to know that the services would not be covered. Consequently, it's important to formally notify the beneficiary in writing of financial responsibility. This applies to both the surgeon and the ambulatory surgery center or other facility. In many cases, they are different providers and two separate waivers are needed. For ordinary Medicare or Part B Medicare, use an advance beneficiary notice of non-coverage with these three options. The beneficiary, not the surgeon or staff, makes the election. Medicare Advantage plans, or Part C Medicare, have been instructed by CMS not to use an ABN. In May 2014, CMS reminded Medicare Advantage organizations that they are obliged to make pre-service determinations of benefits for each plan. Without notice of non-coverage prior to the refractive cataract surgery, the Medicare beneficiary is not financially responsible. For non-Medicare beneficiaries, there is more latitude. A notice of exclusion from health plan benefits is a customizable form that identifies items and services that are not covered under the beneficiary's plan. Using financial waivers prior to surgery is a good way to avoid recriminations later on, particularly if the patient is unhappy. It's important to be clear about covered and non-covered services. This table provides some examples. Where a femtosecond laser is used during cataract surgery, the patient can only be asked to pay for non-covered usage as occurs when making corneal relaxing incisions for the surgical correction of clinically significant regular astigmatism. Other uses, like the capsulorhexis, are an inherent part of cataract surgery and covered. No additional charge to the patient is justified. In 2012, ASCRS and AAO developed clear guidance on this topic. In order to provide the patient with all possible surgical options for the correction of presbyopia and astigmatism, some additional preoperative tests are needed. These tests are not covered under the National Coverage Determination 10.1 for cataract pre-surgery evaluation. If the patient is not willing to pay for these additional services, it probably means they would not be interested in refractive cataract surgery either. If the patient is agreeable to moving forward with these preoperative tests, then advise the patient of the extra cost and get their okay to proceed using the appropriate financial waiver. Professional fees for non-covered services must be reasonable. Is the charge for the service consistent with the charge to other patients for the same services? Grossly disparate charges for the same service are hard to defend. Using Medicare's own logic for creating a payment for surgical procedures, we developed a step-by-step reasonable approach for establishing your professional fee for the non-covered refractive part of the surgery. Begin with a list of appropriate tasks. Include a contingency for refractive enhancements. Assign the frequency of tasks based on your protocol and your experience. Assign your usual and customary charges. Calculate the weighted average for each task and sum for your global fee. This example illustrates the process for determining the professional fee for surgical correction of astigmatism. Note that this amount does not include the ASC's non-covered charge. When an advanced technology IOL is used, it's as if there were two IOLs in the box, a conventional one for cataract and one for astigmatism or presbyopia. It's important to separate the covered and non-covered portions as illustrated here. After a formal request for an official opinion on co-management of postoperative care in cases of refractive cataract surgery, the Office of Inspector General issued a tightly worded favorable opinion with these specific caveats. For practical purposes, there are a few important do's and don'ts as you structure a co-management program for refractive surgery. You should assign roles and responsibilities to the co-managing doctor. Reduce the surgeon's refractive fee to compensate for the work of the other doctor. Separate payments for the ophthalmologist and optometrist for non-covered refractive services performed. Obtain 2 separate ABNs or financial waivers for non-covered services, 1 for each practice. You should not extrapolate Medicare's 80-20 rule to determine value of non-covered services. You should not commingle funds between the surgeon, ASC, and the co-managing doctor. You should not factor in the cost of the IOL. It's irrelevant for the professional fees of co-management. You should not fail to provide patients with a clear description of the co-management arrangement. There are a few themes that constitute best practices for refractive cataract surgery. They are transparency, documentation, separation of monies, and compliance. Thank you for your attention. For additional information, please contact us. We're here to help you.
Hi, my topic today is out-of-pocket payment and financing. My name is Patty Barkey. I'm a certified ophthalmic executive. I am the Vice President of ASOA, the CEO at Bowden Eye and Associates in Jacksonville, Florida, and the creator and director of Dry Eye University. These are my disclosures. Out-of-pocket payment and financing. First rule of thumb in our office is it's a no judgment zone. We have criteria that has been agreed upon that we're going to offer services to patients based on inclusion and exclusion criteria to get them to the end result that they desire when it comes to cataract surgery. We don't judge based on appearance. Just because you're wearing a fancy outfit today doesn't mean you can afford these services, nor does a patient that looks like they're not wearing a fancy outfit mean that they can't possibly afford the services. We're making them as affordable as they can, and we're leaving out the judgment zone. You want to be fully transparent with your fees, fully transparent that the financing options are available. And if I could say, this is an area where I teach our staff, because our premium packages, all of them are over $500, and we can finance or use Care Credit, which is a credit card, not necessarily a financing option. I have them offer the financing options with payments as low as $39 a month or whatever it calculates out to before they ask for a check or cash. And the reason I do that is that many patients have the money, they've got it stockpiled, but they would prefer to use a no interest 12-month package where they can pay for it and never even touch their money in the bank. Likewise, if a patient can't afford to write that check and you offer the financing option first, it makes them a little more comfortable than having to say, I don't have any money available. Do you have a financing option? So let the patient with the money turn it down if they don't want it. Let the patient that needs it get that first offering before they're offered to write a check. That works really well, and it makes everybody more comfortable. Educate patients based on the technologies that are available. It makes it easier for them to make decisions. Don't sell. Teach your staff not to use the word selling or upsell. Instead, it's information and education that we're offering to our patients. The staff, not the physician, should discuss fees with the patient and leave the medical discussions to the provider. Recommend the services to your patients. Don't get in a situation where your counselors fully educated patient, a patient's fully excited, and then you don't even offer the services to the patient. If that happens, just make sure that there was a reason the patient was excluded. That can really kind of bum out the counselor staff and kind of take the air out of their balloon, and they'll pretty soon stop offering to your patients if you're not making the recommendations. Responsibility by committee can create a situation where you have dropped communications that lead to patient confusion. So let's have individuals responsible for collecting money and discussing fees with the patients. They should clearly document in the record what they've discussed with the patient, discuss the financing option. The patient's going to write a check, let the patient know that the money's due a week before the surgery. We usually collect ours either at the time they make the commitment or at the time of the pre-op visit. That may be the A scan, etc. Assign a counselor, surgery coordinator, patient care specialist, etc. to be the collector of the upgraded monies. Then an extra step is always verify insurance prior to the collection of those fees so that you can also collect any other out-of-pocket that the patient may have that their insurance is not going to cover for the standard procedure. Patients get very confused if after surgery they get a bill for their secondary or deductible or whatever that no one told them because they thought when they wrote that big check that that was all they were going to have to write. And then let's talk about what flow could or should look like in your office for an efficient process. So for us, appointment 1 is made, or appointment's made, and that's contact number 1. The call center then flags the counselor, suggests the website review of options, mails or emails information to the patient, and at this point, there's a button on our website where they can go to Care Credit, they can click on the button, they can qualify for a certain amount of money and have it ready when they come to the office. Or you can email a link to them where they can do the same way. The counselor will then call and make contact number 2, which is several things: reminding the patient to bring a family member, suggesting pre-qualification and review of fees, advise fees are due at the visit. We always try to start collecting when they're coming in with their family member. And when you do that, you kind of get some glue going on there where the patient will schedule and not cancel and keep moving if they've made a payment already. The office appointment is then contact number 3, and the counselor will usually look for them, bring them in, show them some videos, start the education process, do Dell questionnaire, etc. Collect at this point if possible. And it's hard because first they have to, if they see the counselor first, then they go to the physician makes the recommendation, and then the counselor gets the patient back. Usually that's our collection moment right there. We want to keep steps pretty clear for our staff and for the patients, because remember, they're going to have a first eye and a second eye, and somebody else might be following along, so keep it pretty consistent. Don't try to add services after a patient has paid. This scares the patient and leads to an increase in cancellations. Make the experience a positive experience for the patients. Consider high upgrade patients as fast-track patients, and make sure that they're acknowledged that their commitment to best vision is a good thing, and celebrate the outcomes with them so that they understand that their investment was a good investment. I want to thank you today. If you have any questions, please let us know.
Hello, my name is John Doe, and I'm going to be speaking on how to handle fees regarding enhancement surgery after premium IOLs and laser vision correction surgery. Before we get started, I would like to thank David, Kathleen, Vance, and Kendall for the opportunity to speak in this 5th section of 20 Happy. My disclosures are the following, but I have no relevant disclosures for this talk. As far as handling fees, there are essentially 2 pricing models that I think are relevant for this discussion. One is a la carte and the other is all-inclusive. With a la carte pricing, we're talking about what does the patient pay for facility fee, surgeon fee, and possibly even extracting the IOL out as a separate line item for payment. Additionally, if the patient needs enhancement surgery, there may be a fee for the surgeon and also a fee for the facility on the second go-around. As regarding all-inclusive pricing, the patient pays a single fee to get to happiness, and this would include the initial surgery and any additional surgery involved in their care. So the ultimate goal either way is certainly patient satisfaction. I'm always reminded of how important it is to get the patient to this end line, and this is really the essence of what we do with refractive cataract surgery and corneal laser vision correction surgery. In this elephant in the far side comic, remember me, Mr. Snyder, Kenya, 1947. If you're going to shoot at an elephant, Mr. Snyder, you better be prepared to finish the job. And I think that is the case with refractive surgery. Where and what do we need to achieve? I think we have to be plus or minus a half a diopter with a sphere, less than a half a diopter, or equal to half a diopter in cylinder, and the spherical equivalent has to be plus or minus a half a diopter. Otherwise, the patient is going to complain of certain things that they want to see: road signs, street signs on the highway, and then certainly the scroller on the TV. So beware, there's certainly landmines aplenty regardless of which pricing model you go with. If it's a la carte, you may be putting a target on yourself. The advantage of this for the patient is a lower entry cost. The disadvantages are additional payments that are going to be required. Again, from far side, this fellow saying bummer of a birthmark, because you can become a target for patient ill will. And why is this patient scorned? Well, if the patient's not on target and they're not happy, then you may be in a position where you have to ask for more money, and they could come back with a comment, doctor, you didn't get it right the first time. You intentionally were off so you could collect more money. Obviously, this is not the case. Nevertheless, you do need to have clear and complete education and communication verbally, and I think in writing up front, to require and minimize ill feelings. I always talk to our staff about trying to avoid post-operative amnesia, and having this written down is probably the key element. There are also other obstacles for all-inclusive surgery, and this may be putting a bridge too far for some patients as far as pricing, but in this model, you are protecting yourself for those occasional enhancements, and I'll try to describe this as we go forward. Importantly, you are essentially amortizing the enhancements across all patients for those few patients that do receive an enhancement, so that the practice is adequately compensated for the extra effort. Either way you go, you can only go one way. So you have to pick your island. It's going to either be the left or the right, a la carte, or it's going to be all-inclusive. And you as a practitioner or surgeon have to make a decision which way you're going to go. You can't go both. What procedures are we enhancing? Obviously, there's a vision correction and its forms: premium presbyopia correcting IOLs, toric IOLs for either axis or magnitude, monovision intolerance, which occasionally we see as a possibility. What about enhancing surgical options, and is there expense? Well, laser vision correction is probably in the middle as far as expense. If you're doing lumbar relaxing incisions either in the surgery center or in the lane, this is less cost, but still is another intervention. Some folks still do conductive keratoplasty, primarily for residual astigmatism. You may have to do an IOL exchange. This is the most expensive avenue one has to take since you're involved in the operating room again. IOL rotation depends upon where you do it, but if you're back to the OR, this will have certain expense to the practice and the surgeon. And what about a piggyback IOL? Again, you're back to the operating room, and additional costs for an additional lens. So who's doing the enhancement surgery? Well, if you're the primary surgeon and you get to shuffle it off to the other guy who may be unassuming or assuming, he's maybe going to say this is not the funnest thing for him. The second surgeon's role is several. He's inheriting a patient whose first surgery did not go as well as he'd hoped. There's some hand-holding and psychology involved, and this is definitely harder than the virgin surgery because there's patient dynamic, and also the patient may be older and may have the potential for dry eye that may have to be dealt with either on the front end or certainly on the back end. And as expected with all these things going on, it may not be a walk in the park for the second surgeon, or the first surgeon has to come back to do the enhancement surgery. Importantly, who's the surgeon? If it's the same as the original surgery, it's essentially a non-issue. If it's different, you need to establish fees up front. Who's paying? Is it the practice-to-practice exchange, all-inclusive, or is it a la carte and the patient has to pay the second surgeon up front? So they've become a couple flies in the ointment as far as I'm concerned. If the IOL surgeon does not do corneal laser surgery, what are you going to do with the monies? Well, let's say there's a $3,000 upgrade for the premium IOL, a $1,000 charge for the lens. That leaves the that leaves the surgeon in the practice with about $2,000, but you still need to do a laser vision correction enhancement. What are you going to do for the LASIK surgeon? Are you going to be sending the money, or is the patient going to be paying? What if the LASIK surgeon's customary price is $2,000? If this comes to pass, the IOL surgeon made $0. So it's not really going to be a practice builder, if you will. The second fly in the ointment may be the following. What if an IOL exchange has to be done? Who's going to eat the cost of the IOL? Does the facility and surgeon have to pay full amount again for the second lens? If so, this is a total financial bust. If there's going to be a full second charge for this facility fee, this may be a deal breaker to opt the premium IOL service altogether. But again, we come back to that's amortization for all cases if you're doing the all-inclusive model. Maybe this is the thing that's going to save you and can allow you to continue doing surgery. Now, there are some potential solutions for the second ointment, second fly in the ointment. You have to work with something out with your facility. If it's your own facility, that's easy. If it's working out with the hospital outpatient department, that may be a little bit more tricky. I do think the lens manufacturers have to step up and take financial risk as well. If it is a team effort, meaning the patient, the surgeon, and the IOL manufacturer, we all can win, but likewise, we can all have to accept some pain if an enhancement is required. This is extra time and money possibly for the patient. The surgeon most certainly is now on a losing end of the financial arrangement, and the IOL manufacturer, as far as I'm concerned, should credit the surgeon 100% for the second lens that needs to be used. The whole goal here, I think, is to avoid what these guys are facing in their pilot training and pilot experience. One says to the other, what's a mountain goat doing way up here in the cloud bank? I think as surgeons and as practices, we definitely have to have excellent surgical acumen. We have to have precise biometry. The whole goal is to minimize. We're never going to eliminate enhancements. We certainly want to minimize it, and we want to optimize the patient experience and certainly the optimization of the financial status of the practice. I hope this talk's been helpful. I want to thank you for your attention, and I want to wish you all the best and have a great session.
That was just a great series of 3 talks, really talking to us very specifically about what the financial obligations are and how that really does impact the psychology of our patients as well. And I want to welcome my panel members, Patty Barkey, Kevin Corcoran, John Doan, and Vance Thompson. And so we're going to dive a little bit deeper there. I want to just go back immediately to your talk, John. I think it's so important to have a plan. You know, that's kind of like you need to have a plan financially for the patient, whether you're the a la carte or the all-inclusive. I've kind of done it either way. There's a psychology behind those 2 ways as well. But I think plan C, which is we don't address it, is that's the loser plan for everybody. So I love the fact that you highlighted that. How do you decide which of those plans? I mean, I think if you're not a surgeon that's doing refractive surgery, that might make it a little bit easier, but you really have to have a relationship with somebody in your environment. And how do you go about doing that?
Are you speaking about finding it if you're not a corneal laser vision correction surgeon, and how do you go about finding that individual to help you out if you're just doing IOLs?
Yes. Yeah.
Yeah. I think it's so important to figure out that piece, because if you're the IOL surgeon and you're trying to have, let's say any of our practice, you're trying to have a Vance Thompson practice in IOL, but you don't do corneal laser vision correction, and you treat the patient really well, and all of a sudden you filter this patient off to a laser vision correction surgeon that is not nice to patients. I mean, that can really make things much worse. So you need to find a really caring and I think compassionate LASIK surgeon. Number one, find the right person. This may be somewhat of a loss leader for your premium IOL practice, but there's going to be some pain involved. Some of these patients, you may not make money. And even if I'm doing the IOL and I have to come back and do the laser vision correction, I'm probably not making a lot of money, but I most importantly want to make the patient happy. So I think you have to look at the long haul of doing enough patients to make it financially viable and make your practice happy and, not cause a lot of problems with your staff. So one, find the surgeon and then deal with the economics. And the economics you just have to figure out. I think most importantly, those individual enhancements, they're not going to be big money winners for you, but you got to just take that lump. That's part of doing what we do.
Yeah, and Kevin, you were saying that, you have to give patients up front a very detailed explanation of what the fees are, and you need to know what they are. And that's always such a hard part of it, because there's also market dynamics. We kind of go, what does the market bear which is not the way we're supposed to approach that, right? So how detailed do you need to be? And one of the advantages, I think, of an all-inclusive type of psychology is just that you're not telling the patient you've already paid for an enhancement, so that if you're withholding it, they think that, well, sometimes it just says, if I paid for it, I need an enhancement, I need a touch-up. So how detailed should those financial disclosures on the front end be to the patient, especially in that all-inclusive model?
I think that's a good question, because some people struggle to try and make this an accounting exercise when in fact it's a medical exercise. I do appreciate the idea, and I tend to favor package prices. The support for the package price needs to be something that you can rationalize yourself. Perhaps the full accounting does not need to be given to the patient. But on the other side of the coin, if you're going to say we're dealing with testing, we're dealing with surgery, we're dealing with post-op, that's probably good enough. The piece that we see in our consulting practice so often is that the prices are simply arbitrary. And the way we know that is they always end with 2 zeros. So when we look at it and say,
There's a take
how
home.
did you arrive at this?
Never ended zeros.
Well, you decide, but if you make it so transparently obvious that it's an arbitrary number, then you're raising some credibility issues. I also think that simple is better. We've heard that before in this program. Don't give 10 different price points. 2 or 3 is plenty. We help practices develop these things, and mostly it's a thought experiment for you. I do believe, and having been in clinical practice myself years ago, I don't like the idea of saying to the patient, gosh, that didn't turn out so well, but for another $1,000, we'll fix it for you. That's not a good plan. So some calculation needs to be done that is defensible. I don't believe patients are looking for a full accounting. I do think they want to be treated fairly.
I love, Patty, your no judgment zone, because that's a trap that we all fall into. We think that this patient should certainly want to have premium lenses, and this patient should, probably can't afford it, and we shouldn't even talk about premium services. And I really like that you have them already dealing with a financial aspect of it by even maybe pre-visit going on and getting approved with care credit. I think that's such a great tip. And so again, how do you get that information to the patient that says, you're going to have potentially some out of pocket, and here's where you could go to maybe have help with it financially ahead of time? What's the smooth way to do that?
I think the transparency of starting ahead of the visit with a surgeon, where we're going to pick what we want, needs to take place so that the patients are prepared. You look at these packages and the different things offered. Most patients today have either copays or they have deductibles, especially if they're on commercial carriers, right, that have large out-of-pocket anyway. So you're addressing the out-of-pocket. So this way you can kind of put it all together to help them. And if you've branded your practice as a refractive cataract practice, patients are kind of expecting that there's some out-of-pocket and that there's some technology options available for them. If you've done anything, and all of us, dermatology practices, dental practices, plastic surgeon practices, there's an expectation for that patient that's walking in for special outcomes that's going to cost them to get what they want. And if they're educated and they know what they want, they can come in prepared. And if I could say on the upgrades or the touch-ups, have a complex package for the known complexity for a patient. If it's a previous refractive patient, and we know that this one's going to be a little tougher, we have a very specific complex package to use for them, so that's a no-brainer. And our other ones, we basically charge them cost. We don't include it in the package, because if you include that in every package, aren't you collecting money that you're not using along the way, unless you have a lot of upgrades going on, or a lot of touch-ups going on? So I think just being prepared and being very transparent with the patients is the way to start out.
So many great pearls in this session. I want to thank the panel. We're out of time for this, but I do want to remind the audience that you'll have a chance to ask more questions in the breakout sessions that come right at the end of this program. So what we have coming up is Dr. Robert Maloney is going to talk about incorporating light adjustable IOL. Michael Debkowski is going to talk about your social presence, website reviews, and social media. Thank you.
Well, thanks. It's a pleasure to be here to speak about the light adjustable lens. My relevant conflict of interest is that I'm an equity holder and consultant for RxSight, the manufacturer. The light adjustable lens was invented by Dan Schwartz and Nobel laureate Bob Grubbs from Caltech. It consists of a 3-piece silicone lens that is made of photosensitive silicone, an injector, and then this device, a light delivery device that applies a specific pattern of light to the lens to adjust its power. Now, specifically the way this works is 2 weeks post-op, you enter the current refraction and the desired refraction into the device. You seat the patient here, place a contact lens on the eye, and then in about a 90-second treatment, very similar to a YAG laser, you apply this specified pattern of light which adjusts the power of the lens. There are typically 2 to 4 light treatments, and the last one locks the power forever. The device can correct up to 2.5 diopters of myopia, hyperopia, and or astigmatism. Now, one of the real advantages from my point of view is that a lot of times you can't figure out a patient's refractive goal before surgery while they have a cataract, and afterwards it's too late. With the light adjustable lens, you basically put the lens in and afterwards figure out the optimal refractive error. It also has an EDOF option where you can get about 0.75 diopters of extended depth of focus in the near eye. Now, you need to decide on your message with this lens and be clear about it. Here's our message. The LAL is our preferred lens. It's the most accurate correction of any lens. If you aren't certain of the vision you want, we can figure it out after the surgery. But it does come with additional costs and visits. Vis-a-vis the multifocal lens, we talk about a great range of vision, but not being as clear far away. It is less expensive than the LAL, and the night vision's not as good. We also offer EDOF lenses. We offer it to patients who basically can't afford the LAL but don't want the glare and don't want the glare of the multifocal. And the toric lens we offer to be with more than 2.5 diopters of astigmatism or those that can't afford the LAL. So that's our positioning. You'll obviously figure out your own, but you need to be clear on where it fits. Now, there's 2 things about the LAL that are different in the post-op course. One is that patients need to wear UV blocking spectacles, shown on your left, for the first few weeks after surgery till the adjustments are completed. The second is that obviously that they have to undergo the adjustments. Here's an example, or here are the UV glasses. On your left is a clear pair with a reading ad, and on your right is the tinted pair for outdoors. I thought this was going to be a big issue for patients, but I found it really isn't. You basically offer patients that they have to wear glasses for a few weeks or they have to wear them for the rest of their lives, and generally they're like, oh, okay, I get that. Now, you do have to make some adjustments to your workflow when you start doing the LAL, otherwise it's like drinking from a fire hose. And also I'll talk about how workflow is different, at least for us. We try and do both eyes of the patients a week apart or less, and that way all the adjustments and lock-ins on both eyes line up, so it halves the number of visits. Don't try and share a light delivery device at a surgery center or with other offices. There are too many visits. It's just, it would be too difficult to do this. Definitely delegate if you can to a fellow, to a junior associate, to a partner who's not that busy. We have our optometrist doing a lot of our light adjustments for us. She learned it very quickly. She's great at it and has taken a load off our shoulders. You have to be careful. Each state has different laws, and whether optometrists can do this depends on the laws in your state. It's okay in California, but it may not be in other states. My partner and I do light adjustments for each other's patients. So if I'm out on a day and a patient needs an adjustment that day, she'll do it, and vice versa. That makes it easier for the patients. Do add light appointments, adjustment appointments to your schedule. Imagine it's sort of like a YAG laser. They've got to be and a manifest fraction dilation treatment. Imagine if you put 4 YAG lasers onto the end of your clinic, it would be chaos. So put them in your clinic schedule. It makes your flow much smoother. And then finally, don't revisit the refractive goal during the adjustment process. Decide before you do the first adjustment on the goal for each eye, and then stick with it. So in summary, the LAL, it's not even a premium offering, it's a super premium offering. You need to give clear message to your patients about the benefits, and then you need to charge enough to compensate yourself for the extra work. And as your volume ramps up, you need to make adjustments to your schedule and your workflow to increase your efficiency. With those adjustments, this can be a great part of your practice. For us, it's now 23% of all our lenses, not just our premium lenses, 23% of all our lenses. So it has an important role in our practice, and really a great, great option to be able to offer our patients. Thank you.
Hello everyone, my name is Michael Dubkowski. I'd like to welcome you to the 20 Happy ASCRS series. My presentation today is entitled The Cataract Surgery Digital Marketing Case Study. First, a few financial disclosures. I am currently the CEO of Glacial Multimedia. I am a Google Premier Partner. I also do consulting for various ophthalmology companies and practices, as well as a co-owner of MD Identity and MD Prospects. I'd like to first get started with the opportunity in front of us. We have a tremendous opportunity to grow our cataract surgery volume and do a lot more surgery over the next 10 years. Cataracts currently affect more than 20.5 million Americans over the age of 40. By age 65, over 90% of people in the US will develop cataracts, and by 75, it will really affect their vision. By 2020, the total number of people with cataracts is expected to grow to 30.1 million. Here's a little data from MarketScope. Total IOL procedures by year in the United States by the end of 2019 was at 4 million. That's tremendous. There's going to be a lot of IOL procedures done in the next 10 years. Let's take a look at it from a Google standpoint, just so you can get an understanding of what's going on out there. There are currently, on a monthly average, over 78,100 different monthly search queries happening, with an estimated 42,400 clicks. Just to familiarize yourself with a few keywords, most of the keywords are not related to premium IOLs, multifocal IOLs. They're actually related to the root term for cataract surgery recovery. Does Medicare cover cataract surgery? What's the cost? These are the types of things that do need to be present in any kind of marketing plan that you would produce down the road. Before we can get started with marketing ideas though, I like to say one thing: make it easy on the OD. Many of you maybe have COPE programs that you do, maybe you have some digital pieces going, some OD portals. Don't underestimate the value of your local ODs and what they can do for your cataract surgery volume. Over the next few years, you're going to see a lot of new technologies come out that are going to make it easier for the OD to schedule appointments inside your practice management software. Reviews are a really big thing and important to nip out of the gate. You want to make sure you have a good star rating on the internet. Nobody really wants to go to a surgeon that has 3.0 stars with complications all over their Google profile. Over 80% of consumers trust reviews as much as recommendations from their friends or family. So this is very important. Let's take a look at some of the things that are important as it pertains to your reviews and local search. It's going to save time, it's going to improve your reputation, boost your local SEO. You need to find a review software. There's tons of them out there. The main barrier though is actually something we refer to as integration. What I've learned is if you don't have an integrated software, you're going to struggle. You're going to get fewer reviews. So you want to find one that's integrated with your practice management software, okay? Let's take a look at what that may look like if you actually do get an integrated version. This practice in particular actually got 133 reviews in the month of July of 2020 this year. You kind of want your review trends to look something like this. And what's more important is not 1 month or this month, but it's the kind of cumulative effect of reviews over the course of the year. You want to be trending at this level. When you have a software that can read your practice management software and automate all the review requests, you're simply going to get more reviews. Here's the case study. We took a look at 2 really good things for digital marketing that produces actual new leads. social media advertising, and paid search. Let's start with the social media advertising, not to be mistaken with organic search. So we had campaigns in 4 regions. Our Southeast campaign spent a total of $1,646, generated 256 leads at a cost per lead of $6.43. Our Northwest campaign had an ad spend of $4,894, generated 407 leads at a cost per lead of $12.03. Our Texas campaign spent over $2,200, generated 269 leads at a cost per lead of $8.23. As you can see, these numbers are tremendously very good. Great cost per acquisition numbers. However, we are interrupting people on the social media front. We do need to remember that intention-based marketing can be a better conversion. That's where we come to PPC. Southeast region spent over $6,900, generated 176 leads at a cost per lead of $40. Northwest, we have a ad spend of $9,100, generated 175 leads at a cost per lead of $52. In Texas, we spent $14,000, came up with 213 leads at a cost per lead of $69. Now you're going to see there's a distinct difference in the cost per acquisition between the social leads and the paid leads. The paid leads are just better quality leads, and they're going to lead to a higher conversion rate. The Fab 5 of cataract marketing are the top things I think you need to worry about when you're putting one of these programs together. A, create a solid value proposition. B, have a great internal process. You need to have someone that's going to be calling these leads back and answering the requests. 3, come up with a digital marketing plan. Even if that's just social media advertising and paid search, that can be all it is. That's going to be effective for you. Don't forget about your physician referrals, as I mentioned with the ODs earlier. And lastly, you need to have a conversion process. What is the process? Okay, set up the internal components. You want to create your funnel, develop a marketing plan. You want to integrate review generation software, establish a referral co-management program if you haven't already, use lead management software, get some post-surgical reviews, and become an authority in your community. Tools required. You need to have a dedicated staff, a solid premium IOL matrix, good, better, best, a website and some landing pages, preferably a lead tracking system with a funnel, often referred to as a CRM system, a general patient communication system, and it would help to have a co-management manual. Thank you very much for watching my presentation today.
Thank you, Michael. And we have a great group of panelists here with Robert, Patty, Kevin, and Michael. And Robert, I'd like to start with you. You were the first person that I even heard about the light adjustable lens. And I just remember how exciting that was way back when, and now it's come to fruition. And one of the things that I find so challenging in a traditional cataract consult is all these things we've used to assess what sort of vision you want when they don't have a cataract, showing them, monovision, or do you want both eyes at a distance, or what do you want? We can't show them, because they have a cataract. So I like to say we're painting word pictures. And the LAL takes so much pressure off. And could you just talk just a little bit about how it's a different patient education process? And I know you talked about it, but just to expand on it for emphasis.
Sure. It's easier ahead of time because you're not trying to figure out, do you want distance? Do you want mini monovision? Do you want full monovision? Unlike multifocals, you don't have to talk about glare, which is nice. And so it's an easier education process. Our biggest barrier, really, the LAL is just it's more expensive. We charge about $2,000 more than our multifocal for the LAL, and so it's generally the lens we'll offer first if they're a good candidate. If they're not interested, we then go to the lower price options. If they're interested, it's very easy because the discussion's over quickly, and then about 2 weeks post-op, Actually, that's not quite true. 1 week post-op, we have them come in to determine the refractive goal, and that can be done in our office or the referring doctor. And that's when all that discussion you just outlined takes place. We show them in a trial frame, we, if necessary, put a contact lens on for a couple of days and let them see how they want their vision. And then starting in 2 weeks post-op, we just implement that goal. And so it makes it easy to delegate the difficult part of the discussion because our optometrists and our technicians can help them figure out what goal they want. It's easy because there's no cataract there. There's no word picture, as you said.
I agree. And I think one of the other beauties is doctors are trying to figure out how to start their premium journey. And I think sometimes, you know, all the analysis that goes into a multifocal beginning in a practice is simplified with the light adjustable lens journey. And that's one of the things that I think doctors like is it's something they're very comfortable with because it's just not that different. They can just now change the power post-operatively. And so
the other thing that's been amazing to me, Vance, is, you know, with my non-LAL patients, if I get the patient within a half diopter of goal, I'm patting myself on the back. I feel good about that. It's a success. My LAL patients, if they're a half diopter off, I feel like I failed.
Yeah.
The accuracy is just so much better than what I'm used to.
So I agree because, you know, adjusting a polymer versus adjusting tissue that has a reaction or a healing reaction. And for those of you out there watching, there is going to be a neat session on the LAL after the breakout sessions. You know, Michael, one of the most challenging things I deal with, because your statement that patients now, 80% of them trust reviews more than friends and family, isn't that huge? And my question for you is, I just have a hard time asking a patient to give me a review. Do I have a problem?
Actually, I don't think you have a problem, Vance. And unfortunately, good doctors get bad reviews, and it just happens. And it's that world we live in. So I wouldn't worry about I would just be yourself. And what I referred to in my presentation was get a good review software that's going to automate and sync with your practice management system. That'll do all the asking for you. You don't have to feel uncomfortable. If you have something that syncs, you're going to get 30 to 40 reviews a month.
And so patients feel okay receiving that little notice, hey, if possible, give me that review. It's not too self-serving.
Well, what's going to happen is your software is going to send out 1,000 requests and you're going to get 30. So.
Okay. And Patty, you know, you've given some beautiful comments. Do you have any thoughts on this review thing, you know, with your experience in practice?
Well, I think you as a surgeon should be very proud of your results. And I think that's your reputation and that's your branding. One of the things we did is we created a little card for the physicians to have in their pocket. And when a patient is gushing and telling you what a wonderful job and how happy they are, just hand them the little card and say, do you mind sharing your experience with others? And it'll have instructions on it and where to go. And that kind of takes the burden off. They're offering it to you. So let them share.
Yeah. And Kevin, I wanted to thank you, you know, for your comments on global fees. I think, you know, since you have experience in ophthalmology, you know, even before becoming a wonderful consultant, you got to see, you know, different methods. And do you think the majority of premium surgeons do, you know, global fees? Is there ever a reason to add to it that would be acceptable?
Actually, what we heard before in terms of inheriting a patient from another doctor, so it was in Dr. Doan's presentation, is the one time where I think a global fee becomes an issue, especially when the patient comes to you with a hostile relationship with the former doctor. But otherwise, in our practice, 99% of people will choose some sort of a package because it's easier to explain, it's quicker to explain, and it's simpler for the patient to take home and talk about it with family or spouse.
And to get more specific with my question, let's say it's someone that you measured tear film pre-op, it just didn't seem like it was an issue, but it is an issue post-op, and you decide you want to do something like LipiFlow. Or do you think that, you know, something like that should be included, or is there times when you could charge extra?
The amount of delay between the post-op period and the point at which you make that determination is going to guide that answer. If it's a year, 6 months, yeah, sure, an extra charge makes some sense. If it's near to the primary surgery, much less so, because the patient will feel it's part of that initial experience. If it's a medical service to deal with an underlying pathology, especially the one that was pre-existing, it should not be part of the package. It should be dealt with outside of the package. If it is something you created during the surgery, then you have to take some ownership of that and probably deal with it as part of your plan for a overall price. A pearl for the surgeons on this program is look at your own data. Go back through your charts and simply tabulate what kind of experience you're having. Are you seeing a lot of enhancements? Are you seeing a lot of piggybacks? Are you seeing a lot of lens exchanges? Usually the answer is no. It's almost always a small number, but knowing what that number is will help you to rationalize your pricing. The slide that was in my presentation showed a table with the intensity of the treatment, the frequency of the treatment, the price of the treatment, and simply the product of all those numbers, and then sum the answer at the end. If you're willing to collect the data, it'll make a huge difference to rationalizing the price tag. And from talking with surgeons, generally they feel good about that.
Thank you. And Robert, quick one, because we need to wrap up this wonderful panel, but you're going for plano -1 with the LAL, and you hit plano -0.75, you do your adjustment, and they're plano -1, but they wish their near was a little better. And when you say kind of stick with your goal until you're done, would you ever, if that patient felt that wasn't enough near, bump it up a little bit?
Yeah, good question, Vance. You know, it's like oversimplifying for the sake of a 6-minute talk. The mistake you don't want to make, and I know you agree with this, is before you do the first adjustment, you figure out their goal. Say it's plano -1.
Yeah.
Then they come back and they're plano -1 after the adjustment, and you say, do you like plano -1, or should we reevaluate this? We could give you a little more myopia if you want. You want to avoid bringing it up. If they're unhappy, for sure, you deal with it right then. And the adjustability lets you adjust the second time, adjust the third time. So you can deal with that. So yes, you're absolutely right. What's your experience, Vance? You've been using this for years, about a year.
Well, I think you're dead on right, because one of the things that doesn't happen right away is neural adaptation. And one of the beauties of the LAL is you're finishing rather quickly. And so what you're saying is, let's go for the goal, and then you'll adapt. But if it's obvious, we can make exceptions. And plus, I think the world of you, so I wanted to trash talk you just a little bit. But a beautiful session, and I just appreciate you all so much, and we're gonna wrap up.
What a terrific program. I'd like to thank all of our speakers today, as well as my wonderful co-moderator, Vance Thompson. You now have an opportunity to interact with our faculty during the breakout sessions. In just a moment, 3 buttons will appear on your screen. You can click on the buttons to select which of the 3 breakout rooms you'd like to join for a 15 to 20-minute discussion. As a reminder, the breakout rooms will cover the following 3 topics. Room 1 is optimizing customer service, and that will be with Vance Thompson, Patty Barkley, and Michael Dubkowski. Room 2 is pearls of managing fees, staff in the premium practice, and that'll be myself and Kevin Corcoran and Alice Epitropoulos. Room 3 will be integrating new technology and techniques into the premium practice with Carrie Solomon moderating, and John Doan and Robert Maloney. So following the breakout rooms, and you can first, let me tell you that you can go between those rooms as well. But following the breakout rooms, please join us at 1:15 for our non-CME event, which is hosted by RxSight and will feature the light adjustable lens. And you will receive a separate login for this event. So thank you very much, and we'll see you in the small breakout rooms.